If you have been taking amlodipine, Losartan, or Lisinopril for your blood pressure and you have mentioned feeling more tired than usual, or noticed your ankles swelling by evening, or felt a strange dry cough that will not go away, and your doctor told you that is just part of getting older, I want you to know something clearly right now. You are not imagining it, and it is not just aging. What you are describing may be a recognized, documented side effect of the exact medication sitting in your bathroom cabinet. And the fact that it gets dismissed so often is one of the most frustrating patterns I see in my own practice. Today, I am walking through 6 specific effects connected to these 3 extremely common blood pressure medications. Effects that are well documented in medical literature, but that get waved away in routine appointments far more often than they should be. By the end of this video, you will understand exactly what your body might be telling you, and more importantly, exactly what to say to your doctor so that your concerns get taken seriously instead of attributed to a vague concept of simply growing older. The 5th effect on this list is the one I have personally seen take the longest to get properly diagnosed, because it mimics something else entirely. Before I go through each one, I want to explain why this dismissal pattern happens so often, because understanding the mechanism behind it actually helps you advocate for yourself more effectively. Amlodipine, Losartan, and Lisinopril belong to 3 different drug classes: a calcium channel blocker, an angiotensin receptor blocker, and an ACE inhibitor respectively, and they are among the most frequently prescribed medications in the world for managing blood pressure, which means doctors prescribe them constantly and have seen thousands of patients tolerate them without major issue. This familiarity, paradoxically, can work against careful evaluation of side effects, because when a medication is this common and this well established, there is a tendency to assume that any new symptom appearing in an older patient is more likely related to age itself than to a medication that has been prescribed safely to millions of people. Add to this the reality that many appointments are brief, sometimes 15 minutes or less, covering multiple concerns, and a vague symptom like fatigue or mild swelling can easily get attributed to the most statistically common explanation, which in an older patient is often assumed to be age-related decline rather than a specific, addressable medication effect. There is also a subtler factor at play, which is that many of these side effects develop gradually rather than appearing suddenly, which means there is rarely a single dramatic moment that clearly signals something has changed. A slow increase in afternoon fatigue over several weeks, or ankle swelling that creeps in so gradually that it only becomes obvious when shoes start fitting differently, does not announce itself the way an acute symptom would, which makes it far easier for both patients and physicians to normalize these changes as simply part of getting older, since there was never a clear before and after moment to draw attention to the shift. This is not because your doctor does not care. It is because the system often does not give them enough time to investigate every symptom as thoroughly as it deserves, which means the responsibility sometimes falls on you to bring specific, well-articulated observations that make the connection to your medication clear and difficult to dismiss with a general explanation. The first effect, and one of the most common with amlodipine specifically, is peripheral edema, meaning swelling in the ankles, feet, and lower legs, often worse by the end of the day and improved somewhat after a night of lying down. This happens because amlodipine works by relaxing and widening blood vessels, which is exactly the mechanism that lowers your blood pressure. But this same vessel widening can cause fluid to leak out of capillaries into the surrounding tissue more easily than usual, particularly in the lower legs where gravity already encourages fluid to pool throughout the day. This is genuinely one of the most well-documented side effects of this specific medication class, appearing in a meaningful percentage of people who take calcium channel blockers like amlodipine. And it tends to be dose-dependent, meaning higher doses produce more noticeable swelling than lower doses. The frustrating part is that this swelling gets attributed reflexively to age, to sitting too much, or to general circulation problems associated with getting older, when in many cases it resolves significantly or completely if the dose is adjusted, or if a different blood pressure medication is substituted. If you have noticed this pattern, ankles that swell progressively throughout the day and improve overnight, specifically since starting or increasing amlodipine, that timing connection is exactly the kind of specific observation that makes this much harder for a doctor to wave away as simply aging, because true age-related circulation issues typically do not track this closely with medication timing and dosing changes. The second effect, closely associated with both Losartan and Lisinopril because of how these medications affect a hormone system called the renin-angiotensin system, is a notable drop in energy and a sense of mental fog that many patients describe as feeling like they are operating through a haze, particularly in the first few weeks after starting or increasing the dose. This occurs partly because these medications lower blood pressure, And if blood pressure drops more than your body is accustomed to, blood flow to the brain can decrease slightly, especially when standing up quickly or in the morning before your body has fully adjusted to its daily rhythm. Additionally, both Losartan and Lisinopril affect potassium levels in the body, often raising them modestly, and even small shifts in potassium can influence energy levels and cognitive clarity in ways that are subtle but genuinely noticeable to the person experiencing them, even when blood test results technically fall within a normal range. This is precisely the kind of effect that gets dismissed easily because fatigue and mental fog are such common, non-specific complaints in older adults generally, with dozens of possible explanations ranging from sleep quality to thyroid function to simple overexertion. But if this fog appeared specifically after starting or adjusting one of these medications, and especially if it improves on days when you happen to take the medication later or skip a dose under medical guidance for testing purposes, that specific pattern is meaningful information your doctor needs to properly evaluate whether your current dose or medication choice is right for you. The third effect, and one that is almost exclusively associated with lisinopril and other ACE inhibitors specifically, rather than losartan or amlodipine, is a persistent dry cough that has no other identifiable cause. No cold, no allergy, no postnasal drip, just a nagging, irritating cough that seems to come from nowhere and will not resolve with typical cough remedies. This happens because ACE inhibitors block an enzyme that, among its other functions, breaks down a substance called bradykinin in the lungs and airways. When this enzyme is blocked, bradykinin accumulates, and elevated bradykinin levels irritate the airways in a way that produces a characteristic dry, tickling cough in a meaningful percentage of people taking this medication class, sometimes appearing within days of starting the medication, but sometimes not appearing until months later, which makes the connection genuinely harder to recognize without specifically knowing to look for it. This particular side effect is extremely well documented in medical literature, well known enough that it is actually one of the most common reasons doctors switch a patient from an ACE inhibitor like lisinopril to an angiotensin receptor blocker like losartan. Since losartan works through a related but distinct mechanism that does not cause this same bradykinin accumulation and therefore rarely produces this specific cough. If you have developed a persistent dry cough since starting lisinopril, and especially if you have already ruled out the more obvious causes like allergies or a respiratory infection, this is one of the clearest, most directly attributable connections on this entire list, and it is worth bringing up explicitly using the words ACE inhibitor cough, since that specific terminology often prompts immediate recognition from a physician in a way that simply describing a persistent cough might not. The fourth effect involves changes in taste perception. Something patients describe in various ways: food tasting bland, a persistent metallic taste, or a general sense that meals simply do not taste the way they used to, which can be genuinely distressing because eating is such a fundamental part of daily quality of life and social connection. This effect has been documented with several blood pressure medications, including ACE inhibitors like lisinopril, and is thought to relate to how these medications can affect zinc levels in the body, since zinc plays an important role in how taste receptors function, and certain blood pressure medications appear to interfere with zinc absorption or increase zinc excretion over time. This is precisely the kind of symptom that gets attributed to aging almost automatically, since taste perception genuinely does change somewhat with age for many people independent of any medication, which creates a convenient but sometimes inaccurate explanation that prevents the medication connection from ever being explored. If you have noticed a relatively sudden or pronounced change in taste, rather than the gradual, subtle shift that typically accompanies normal aging, and if this change coincided with starting or adjusting your blood pressure medication, that timing distinction matters and is worth specifically describing to your doctor, since a relatively rapid onset is more consistent with a medication effect than with the slow, gradual changes typically associated with age alone. The fifth effect, the one I mentioned takes the longest to properly identify because it mimics something else entirely, is a specific type of dizziness that occurs primarily when standing up from sitting or lying down, sometimes severe enough to cause brief lightheadedness, or even a stumble, a phenomenon called orthostatic hypotension. This happens because all three of these medications lower blood pressure through different mechanisms, and your body's natural reflex system, which normally adjusts blood vessel tone instantly when you change position to prevent blood from pooling in your legs and away from your brain, can become less responsive when blood pressure is already being pharmacologically lowered. The reason this so often gets misattributed is that this exact symptom, brief dizziness upon standing, is also incredibly common as a standalone sign of normal aging, since the body's blood pressure regulation reflexes do naturally become somewhat less efficient with age, regardless of medication. This overlap creates a perfect storm for dismissal, because the symptom genuinely can occur from aging alone, which makes it easy for a clinician to default to that explanation without specifically considering whether the medication itself, or a dose that may now be slightly too strong for your current weight or kidney function, might be contributing significantly or even primarily to what you are experiencing. The way to distinguish this in your own observation is timing and severity. Dizziness that occurs specifically and consistently within the first few minutes of standing, particularly worse in the morning or after the medication has just been taken, and severe enough to require holding on to furniture or a wall, is more suggestive of a medication-related blood pressure drop than the milder, less consistent dizziness that sometimes accompanies normal aging. The sixth effect, and one that deserves particular attention because of how seriously it can affect kidney function if not monitored, is a subtle decline in kidney function markers that can occur with both Losartan and Lisinopril, since both medications work in part by altering blood flow dynamics within the kidneys themselves as part of how they lower blood pressure. For most people, this effect is minimal, and the kidneys adapt well, which is why these medications are not just safe, but often specifically protective for kidney health in people with diabetes or certain other conditions. However, in a smaller subset of patients, particularly those who become dehydrated, who are taking certain other medications simultaneously, or who have some degree of underlying kidney artery narrowing that may not have been previously diagnosed, these medications can cause a meaningful decline in kidney function that shows up on blood tests as a rising creatinine level or a falling measure called the glomerular filtration rate. The reason this connection so often gets missed in routine care is that kidney function naturally and gradually declines with age in nearly everyone to some degree, which means a doctor reviewing a slightly elevated creatinine level in an older patient may reasonably attribute it to expected age-related decline, rather than specifically investigating whether the blood pressure medication dose needs adjustment, particularly if blood work is not being repeated regularly enough to establish a clear trend over time, rather than a single isolated value. This is exactly why I recommend that anyone on these medications, particularly Losartan or Lisinopril specifically, have kidney function blood tests checked at least annually, and ideally within a few weeks of starting the medication or increasing the dose so that any meaningful trend can be identified early while it is still easily reversible, rather than discovered later after more significant kidney impact has already occurred. I want to spend a moment on something that connects all 6 of these effects together, which is the importance of timing in how you describe symptoms to your doctor, because the specific language you use can dramatically change whether a symptom gets investigated thoroughly or attributed to general aging. Rather than saying something vague like, "I have been feeling more tired lately," which is easy to attribute to countless possible causes, try to be as specific as possible about timing and pattern. Something like, "My fatigue started about 3 weeks after my lisinopril dose was increased, and it is worse in the mornings before I have eaten," gives your doctor a specific, investigable thread to pull on, rather than an open-ended complaint that could have dozens of explanations. This same principle applies to every symptom we have discussed today. Specificity about onset timing relative to medication changes, specificity about which time of day or circumstance makes a symptom better or worse, and specificity about how a symptom differs from your normal baseline, all of these details transform a vague complaint that is easy to dismiss into a focused clinical question that essentially requires investigation rather than a generic reassurance. I also want to address something that I think gets lost in conversations like this, which is that none of what I am describing today is an argument against taking these medications. Amlodipine, Losartan, and Lisinopril are, for the vast majority of people who take them, genuinely effective, well-tolerated medications that meaningfully reduce the risk of heart attack, stroke, and kidney disease associated with uncontrolled blood pressure. The point of this video is not to create fear around these medications, or to suggest you should stop taking them, or view them with suspicion. The point is precision. These medications can cause specific, identifiable, and often manageable side effects in some people. And when those side effects occur, they deserve proper identification and management, rather than a default explanation of aging that closes the door on further investigation. Sometimes the appropriate response to identifying one of these side effects is simply adjusting the dose. Sometimes it means switching from one medication to a different one within the same general category that does not produce the same specific effect, such as switching from Lisinopril to Losartan specifically to resolve a persistent cough. And sometimes, after careful evaluation, the conclusion genuinely is that the symptom is unrelated to the medication and does reflect something else happening with your health that deserves its own separate investigation. The goal is simply making sure that conclusion is reached through actual evaluation rather than reflexive assumption. Let me also address something practical, which is what to actually do if you recognize one or more of these patterns in your own experience after watching this video. The first step is not to stop your medication on your own, since abruptly stopping blood pressure medication can itself be dangerous, sometimes causing a rebound increase in blood pressure that is more immediately risky than the side effect you are trying to address. Instead, the appropriate first step is scheduling a specific conversation with your prescribing physician, ideally bringing a written note describing exactly when the symptom started relative to your medication timeline, how it has progressed, and what specifically makes it better or worse. If your usual physician seems to dismiss the connection despite this specific information, it is entirely reasonable to ask directly whether this particular side effect has been considered using the specific terminology we discussed today, such as asking explicitly whether your cough could be related to the ACE inhibitor class of medication, or whether your ankle swelling could be related to the calcium channel blocker mechanism of amlodipine specifically. Physicians generally respond well to specific, informed questions, since it gives them a clear clinical pathway to investigate rather than an open-ended concern. And if you continue to feel unheard despite bringing specific, well-documented observations, seeking a second opinion from another physician or a pharmacist who specializes in medication management is a completely reasonable and often valuable next step. There is another layer worth understanding here, which is how certain foods and other common substances interact with these three medications specifically. Because some of what gets attributed to age-related side effects is actually a food interaction that is entirely correctable once identified. Grapefruit, in particular, has a well-documented interaction with amlodipine specifically, since compounds in grapefruit interfere with an enzyme in your liver and intestines that normally breaks down this medication, which means eating grapefruit or drinking grapefruit juice regularly while taking amlodipine can cause the medication to accumulate at higher levels in your bloodstream than your prescribed dose was intended to produce, potentially intensifying every single side effect we discussed today, including the swelling and dizziness, simply because the effective dose in your body is higher than what appears on the prescription label. This is genuinely one of the most well-known drug-food interactions in all of medicine, yet many patients are never specifically told about it, particularly if grapefruit was not a regular part of their diet at the time the medication was originally prescribed, only becoming relevant later if dietary habits change. If you regularly consume grapefruit or grapefruit juice and you are taking amlodipine, this is worth mentioning explicitly to your physician or pharmacist, since the solution is often as simple as avoiding grapefruit specifically, rather than needing to change the medication itself. Potassium intake deserves separate attention specifically for Losartan and Lisinopril, since both medications work in part by reducing how much potassium your kidneys excrete, which means potassium levels in your blood tend to rise modestly while taking these medications. For most people eating a typical diet, this effect is mild and well tolerated, and in fact, is part of why these medications are sometimes specifically chosen for patients who have a tendency toward low potassium from other causes. However, if you are also taking potassium supplements, using salt substitutes that are potassium-based rather than sodium-based, which many people switch to specifically because they were told to reduce sodium, or eating very large quantities of potassium-rich foods like bananas, potatoes, or certain leafy greens consistently, the combined effect can push potassium levels higher than is safe, a condition called hyperkalemia that can cause exactly the kind of fatigue and mental fog we discussed earlier, along with more serious effects on heart rhythm in more pronounced cases. This is precisely why regular blood testing while on these medications matters so much, since it can catch a potassium level trending upward before it becomes a significant problem. And it is also why I specifically ask patients about salt substitute use, since potassium-based salt substitutes are common enough, and their potassium content significant enough, that this single dietary detail can meaningfully shift blood potassium levels in someone taking Losartan or Lisinopril. I want to walk through an example of how these effects tend to surface in real life, because seeing a realistic pattern often makes it easier to recognize something similar in your own experience. Consider someone who started Lisinopril for blood pressure about 8 months ago and who began noticing a dry, scratchy cough roughly 6 weeks after starting the medication, attributing it initially to seasonal allergies since that timing happened to coincide with a change in season. The cough persisted through allergy treatment without improvement, eventually prompting a visit where it was mentioned to a physician, who, given the patient's age and the unremarkable nature of a persistent cough in an older adult, suggested it was likely a mild chronic respiratory change associated with aging, possibly worth monitoring rather than actively treating. 8 months later, the cough remained essentially unchanged, now simply accepted as a permanent feature of daily life that the patient had stopped mentioning at appointments since it had already been addressed and seemingly dismissed once. It was only when this patient specifically researched ACE inhibitor cough by name, recognized the connection to lisinopril timing, and brought this specific terminology to a follow-up appointment that the conversation shifted meaningfully, leading to a switch from lisinopril to losartan, after which the cough resolved completely within roughly 2 weeks. This entire 8-month period of unnecessary discomfort existed not because of any failure in medical training or genuine care, but because the initial symptom was presented in general terms, allergies or aging-related changes, rather than with the specific medication timing connection that would have prompted a more targeted investigation from the very first appointment where it was mentioned. I also think it is worth mentioning that these 3 medications are sometimes prescribed together or alongside other blood pressure medications entirely, particularly for people whose blood pressure remains elevated despite a single medication, which is an extremely common and often appropriate treatment approach. When multiple blood pressure medications are combined, the side effects we discussed today do not necessarily add together in a simple, predictable way, but the overall likelihood of experiencing at least one of them does tend to increase somewhat, simply because you now have multiple distinct mechanisms acting on your cardiovascular and kidney systems simultaneously rather than just one. This is not a reason to avoid combination therapy when it is genuinely needed to achieve adequate blood pressure control, since uncontrolled blood pressure carries its own serious risks that generally outweigh the risk of these manageable side effects. But it is a reason to be even more attentive to the specific symptom patterns we discussed today if you are taking more than one blood pressure medication simultaneously, since identifying which specific medication within a combination is responsible for a particular side effect becomes more complex and may require your doctor to temporarily adjust one medication at a time to isolate the source, rather than assuming any new symptom is simply an inevitable consequence of needing multiple medications. One more practical tool worth mentioning is keeping a simple symptom log at home, since memory alone, especially when trying to recall exactly when something started weeks or months ago, tends to be far less reliable than a written record kept in real time. This does not need to be complicated or time-consuming. A small notebook or a simple notes app on your phone with a quick entry whenever you notice ankle swelling, unusual fatigue, dizziness upon standing, or any other change, including the date and roughly what time of day, creates a genuinely useful record that you can bring to appointments rather than relying on memory under the time pressure of a brief visit. Many patients find that once they start this kind of simple tracking, patterns become clear that were not obvious before, such as realizing that dizziness consistently happens within the same hour after taking a morning dose, or that ankle swelling specifically worsens on days with less fluid intake or more time spent sitting. This kind of pattern recognition is exactly the information that transforms a vague complaint into a specific, actionable clinical observation, and it costs nothing beyond a few seconds of attention each day. I want to close with something I think matters beyond the specific medical details we covered today, which is a broader point about trusting your own observations about your body. You live in your body every single day, and you are uniquely positioned to notice subtle changes and patterns that a physician, seeing you for 15 minutes every few months, simply cannot observe with the same continuity and detail that you experience firsthand. This does not mean every symptom you notice is necessarily related to your medication, and it does not mean medical training and expertise do not matter enormously in properly interpreting what you are experiencing. But it does mean that your specific, detailed observations are genuinely valuable clinical information, not simply anecdotal noise to be waved away with a general explanation about aging. The 6 effects we discussed today, swelling, fatigue and mental fog, persistent dry cough, taste changes, dizziness upon standing, and subtle kidney function changes, are all genuinely documented, genuinely real phenomena associated with these specific medications. And bringing them to your doctor's attention with the specificity we discussed today gives you the best possible chance of getting the thorough evaluation your concerns deserve, rather than a dismissal that leaves you wondering whether something correctable is simply being attributed to growing older. If any of these 6 effects sounded familiar to your own experience, or if you have a specific question about how one of these medications might be affecting you, leave a comment below describing what you have noticed. because I read every single one, and these specific details often help me understand exactly what to cover in future videos that might help you and others watching get the answers you are looking for. Take care of yourself, and I will see you in the next one.